Thank you, Antoine, and thank you to the Foundation for inviting me to speak today. Just a little bit about me, my background. I'm pretty new to the sickle cell world. I finished a residency in combined pediatrics and internal medicine after I finished medical school. And so I really love taking care of patients of all ages. And when I was deciding what to do after my residency, I knew I had a love of sickle cell disease and other blood disorders. So chose to do a pediatric hematology and oncology fellowship, which I completed just last year at Benioff Children's Hospital in Oakland. And have been really fortunate because of the opportunities here in the Bay Area where I grew up to take care of not just kids, but also young adults and older adults with sickle cell disease, as well as other blood disorders like thalassemia. I've been really, really excited to be invited to be a part of the team at the Zuckerberg San Francisco General Hospital, which has been run spectacularly by Robin McBride and the rest of the team for the last several years. But actually with some funding from the state and through other foundations that have invested a lot more effort, energy, and money into sickle cell disease, we've been able to come up with a pretty amazing team that I'm really lucky to be a part of. And I want to pass the mic over to some of my other team members, Kristen Lockhart, Celeste Balaban, and Robin McBride here, to let you know a little bit more about how the structure at Zuckerberg San Francisco General is changing and what we are hoping to do to enhance the care and experience for people in San Francisco and the greater Bay Area living with sickle cell disease, as well as people advocating and taking care of them. So let me pass the mic to Kristen, who can tell you a little bit more about our program.
Good morning. Can you guys hear me?
Good morning.
Okay, thank you for having me. I'll just give a little background about myself before I kind of get into the team. So prior to coming to UCSF, I worked in hematology and oncology for 3.5 years at Stanford. And I actually have sickle cell trait myself. So I felt like this job was, it wasn't a job, it was something that I felt like we needed in the community. And so I was really excited to be on board. Since coming on board in January, we've most so focused on patient engagement and outreach. And through that, we've been able to determine a lot of barriers that oftentimes prohibit our patients from being able to come and seek care. Just a little background, some of those barriers range from incarceration, transportation, housing, mental health issues. So what we've really focused on right now is like a patient-centered approach to reducing those barriers so that we can help our patients receive care. And I'll pass it to Celeste to give a little bit more detail.
Hi, I'm Celeste. I'm the sickle cell social worker. So glad to be here. I really enjoyed the mindfulness earlier too. I just wanted to say that it really set me for the day. So I appreciated that. One thing I've noticed in the 6 months since I've been here is before I was in sickle cell, I was in the cancer center. And I just really noticed the disparity between services, between, all the things, several things that were available. And so I'm just really passionate about this population and about really using my voice to close that disparity. It's just really important to me. I think one of the things, as Kristen said, that we've really been focusing on is the patient-centered care. So Robin McBride developed this needs assessment. So it's not just us saying, well, this is what we think the patients need. Here are our goals, let's make it and do it. But really, let's hear from our patients. What is important to you? What do you feel like is missing? What's valuable? And we took that information and we're continuing to take that information and then develop what's important and what our goals as a team are and how we can serve the patients based on those things. So we've been able to advocate for CAB vouchers so that our patients can make it to appointments and make sure they have insurance and housing and just all of these things that are so important. It just goes beyond, just what's right in front of you care, but to the kind of whole self-care, mental health resources. We've created kind of a pathway for patients to continue to have that care. We're also trying to expand to neuropsych testing. So it's not just the body and how sickle cell disease is affecting the body, but it's also the brain. and what's going on there and how we can give resources and support in that area. And I think, you know, overwhelmingly, we've heard from the patients too, over and over, that like, I know my body and I know what's important to me and wanting to be treated as an expert in care. And so really being able to support and amplify that as we move forward. And so we're kind of talking about how to do that as a team as well. So I'm really thankful to be a part of the team. Thank you guys so much for having us. And I know we feel honored to partner with you. And I'll pass it over to Robin if she's available to say hi.
Good morning, everyone. Thank you for setting this up, Nadina. I'm actually not going to be on a video right now because I'm masked. My husband tested positive for COVID this morning. We're having a bad COVID month in our family. Anyway, I have to say with regard to the program, for so long, I have felt kind of like marooned on a desert island with regard to just our program. We have traditionally not had many resources, and it's just been a blessing and a pleasure to have so many new passionate people. We've doubled the size of our staff in the past 6 months, and I have to say, Kristen and Celeste and Madhav have just jumped right into the deep end and just have been so wonderful. And I think I'm hoping that all of our patients already are feeling a big difference with regard to support and just what our program has to offer. We have just been spread so thin for so long, and with with COVID the past 2 years, that has been even worse. So I feel like we've turned a corner, and it's so wonderful to have to have these new team members. So yeah, I think that's all I'm going to say today. Thank you.
Thank you. Stephanie, do you have something to say? Good morning.
I just wanted to say I'm one of her patients, and it has made a really big difference. Hi, Robin. It has made a really big difference in how the center functions, and it's nice to have the support of those ladies who, when I come in all frazzled and falling apart, manage to put me back together and do things that I cannot. So I'm very grateful for them and for Robin for being such a strong advocate. That's all. Thank you.
Thank you,
They
Stephanie.
usually put me back together when I'm frazzled on Mondays too, so I appreciate it. Well, thank you, team. It's, like Celeste said, it feels like we've been at this for a long time, but it's only been 6 months. So it's, I think we have a lot of work to do, and we're, as everybody already said, the biggest thing that we got to do is listen to the people we interact with and hear what we need to be working on. And part of that, of course, is managing symptoms, managing pain, helping people preserve their quality of life today. But when it comes to the momentum in sickle cell disease, just that I'm feeling as a new person in the field, both locally and nationally, there's so many new therapies, there's so much research, there's a lot of new drug trials that are on the market. And I feel like we are really in a new exciting field of a new exciting time where we can really work towards not just making life better today, but prolonging life, making life, the quality of life good for years and years to come. And that is my goal for taking care of people who live with sickle cell, is to make you feel good today and make you feel good for a really long time. And so that's kind of the, what I wanted to talk about today is what we're calling disease modifying therapies in sickle cell disease. Before I get started, I just wanted to ask, is there anybody else who kind of wanted to talk about the structure of our program, kind of what our goals are?
Yeah, I'd like to know what your goals are.
Yeah, I could just tell you what my personal goals are and kind of echo what the rest of the team is. But, our goal is to be a center that people can rely on for their comprehensive sickle cell care. And what that means is making sure that they're sickle cell disease is under good control, but all of the things that are related to sickle cell disease, whether it's their organ function, screening is up to date, whether it's their pain, that is being optimized, whether it's their, how sickle cell disease is affecting their, finances or affecting their relationships. All of that stuff is, to the best of our ability, a priority to at least think about and at least empathize with, but ideally to help with. And of course, we can't promise that we're going to solve all the problems, but we can certainly promise that we'll do our best. And at the very least, we'll be partners in this journey together. I don't know if anybody else on the team has a kind of similar or different goal. Great. All right. Is it all right if I just kind of jump into this?
Let's do it.
All right. So today I want to talk about, like I said, it's called disease modifying therapy. And what does that really mean? This isn't really medicines that are affecting, daily pain. These aren't, I'm actually not really talking about pain medicine today. So we can certainly discuss that later on during the Q&A if it comes up. But what I want to talk about is really what causes the symptoms and what causes organ dysfunction in sickle cell disease, and what are we trying to do to preserve just general health. I want to make sure that we're addressing the problem of sickle cell disease and how it impacts the body, and then our current strategies to reduce that. I actually created this talk for other healthcare providers. I presented this to our division in hematology as well as to some nurses. And so it does have some kind of high level clinical trial information. It has a lot of more scientific details. And I thought a lot about kind of paring it down, bringing it to, for this audience to change it. But then I decided, I don't want to water it down. I don't want to change the concepts. I want to make sure that people are getting an honest, straightforward presentation that talks about how I, as a hematologist, think about these medicines and how they can help my patients. And so certainly we can stop and talk about kind of details. And there's a lot more information on these slides than I think I'm going to say out loud. But like Antoine said, they'll be available for you to look. And of course, I'm happy to answer any questions later on. But this is going to be a very kind of high level discussion about the different drugs that are available for sickle cell disease. So just briefly, my outline today is I'm going to talk just briefly about sickle cell disease and what causes you to get sick from sickle cell disease, the pathophysiology, because I think that informs how we decide treatments for it, because if we need to understand what's causing problems in order to target them. And then you all may have heard of these medicines, Hydroxyurea, L-Glutamine, Voxelitor, and crizanlizumab. And I'm going to spend a little bit of time discussing what we know about them, why we might choose to use them. And then I'd love to hear if anybody on the call has experience, not just with taking these meds, but with how their providers have talked to them about these medications. I think that is something I want to spend a little bit of time on. I want to just mention what we call curative therapies. I put it in quotes because there's some debate about whether you can ever really cure someone of sickle cell disease rather than just kind of permanently modify it. Things like bone marrow transplant and gene therapy. So I want to mention those just so you've heard about them, and then we'll just wrap up and answer any questions you have. So this is probably not news to anybody, but just to kind of really set the tone. Sickle cell disease has been a known syndrome for thousands of years, and it's had a lot of names, interestingly, in many of the tribal cultures in Africa and other places where sickle cell disease occurs. It's typically, the name for it is synonymous with pain. It's something that describes pain. So of course, this is something that we know is a really remarkable feature about it, but it wasn't really described or discovered, or nobody really thought about it until 1910, when this dental student from the Caribbean came to Chicago for his clinical rotations, and he had these episodes of anemia, he had pain, and this doctor, Dr. Herrick, actually looked at his blood under the microscope and noticed that it looked unusual. He had these really long, elongated red blood cells that was the first description of sickle cell disease. But, we can talk about why it took such a long time. I think we can all have our hypotheses. It took a really long time for anybody to really pay more attention to this and think about it more. And it wasn't until the 20s and 40s where people started to really understand what the what was causing this. And it wasn't until the 50s that we understood really what the genetic cause was, is this mutation that led to sickling of red blood cells. And despite all of this, it was almost a century later that the first medication was approved to treat sickle cell disease, and that was hydroxyurea. A lot of this is informed actually by social movements and things just like this, where it was people, it wasn't scientists, it wasn't doctors, it was people who knew about sickle cell disease, people who were living with sickle cell disease, really part of the civil rights movement and the Black Panther Party that played a big role in widespread screening and newborn screening. And actually it was in the 70s, President Nixon signed the National Sickle Cell Anemia Control Act that led to the formation of this large study. It's called the Cooperative Study of Sickle Cell Disease. And a lot of people were enrolled on this that allowed us to track the organ function, track blood parameters, track symptoms. And that's really how we learned what we know now about sickle cell disease. There's about 4,000 patients from 23 sickle cell centers around the country. And really most of what we know about sickle cell disease came from there. And so you can see in this graph at the bottom here, life expectancy until the 70s was in the teens. It was just so far below what we should expect. But since the National Sickle Cell Control Act and the discoveries that came after that, like penicillin, like transfusions, like hydroxyurea, life expectancy is so much higher now, but of course nowhere near where it ought to be. I think that my goal in my career in my lifetime is going to be for sickle cell disease to be to have no shorter lifespan than anybody else in the population. And so what is sickle cell disease? Again, just to define things, this is a single mutation in the beta globin chain of hemoglobin that causes an abnormal hemoglobin molecule that forms long strands. So hemoglobin shouldn't really bind to itself, but when it is not bound to oxygen, it can form these long strands that can deform the red blood cells. And there's a lot of other genetic things that can be inherited with sickle cell, like thalassemia or hemoglobin C, that can kind of change how it presents. In the United States, there are about 100,000 people living with sickle cell disease, but it's a much, much more prevalent issue globally, especially in sub-Saharan Africa, in South Asia, in the Middle East, also in Latin America. And it's what's so striking to me and what's so just boggles my mind is that it's one single mutation. It's one little change in the DNA that everybody with sickle cell disease shares, but the variability in how people present in terms of how severe their disease is, life expectancy, number of hospitalizations, et cetera, it can be so variable where you can have somebody who has the exact same mutation, two people, one person who has no pain, who's really not having any symptoms, and somebody else who's in the hospital frequently. To do our best to understand what is that's changing that, that's different in those patients who have a more severe disease that we can target as providers. And please let me know if I'm cutting in and out. I'm sorry if my internet kind of stinks here at my house. And as you guys know, the hallmark feature of sickle cell disease is severe pain, but I think that we do a disservice to people living with sickle cell if pain is the only thing that we address, because sickle cell is a problem with blood, and blood goes everywhere in our body to deliver oxygen. So anywhere blood goes, we have to be mindful of and we have to be addressing. So things like the cardiopulmonary system, heart and lungs. You can get things like acute chest, asthma, clots in the lungs are called pulmonary embolism, pulmonary hypertension, which happens later in life. As Celeste said, we worry about not just strokes when it comes to the brain, but also cognitive impairment, thinking problems, school problems, work problems. That can lead to impaired quality of life because, holding a job, having, a functional life, we want you guys to have as good a life as you can. And if we're not addressing the effect of sickle cell on your brain, then we can do better than that. People with sickle cell can also develop kidney issues. They can develop priapism, that's for boys, that's prolonged painful erections. People can develop liver issues like iron overload from transfusions or gallstones. We worry about infection. ID is infectious disease because of the lack of spleen function. And then of course, musculoskeletal things like leg ulcers or bone pain, avascular necrosis. This is just a short list of the systemic issues that we have to think about when we're taking care of people with sickle cell disease, and make sure that if we're only addressing pain, that we're not missing all these other really important things that can not only impact the quality of life, but can impact the duration of life. You know, these are the things that we need to address in order to keep you guys healthy and safe for a long time. So just to revisit, what is hemoglobin? We keep talking about this molecule hemoglobin. So hemoglobin actually consists of 4 proteins. There's 2 alpha globin proteins and 2 beta globin proteins, and they all carry a molecule of heme, which is why it gets that name hemoglobin, and heme carries iron in it. So that's what makes our blood red. And the primary function of hemoglobin is to carry oxygen to all of our tissues. When not bound to oxygen, normal hemoglobin just, hangs out how it is, but sickle hemoglobin, or hemoglobin S, forms these long strands that we call polymers. And these long strands can distort the red blood cell and lead to the breakdown or hemolysis of red blood cells. The rate of this polymerization happening is proportional to the amount of sickle hemoglobin, hemoglobin S, but it's inversely proportional. So the more hemoglobin F you have, fetal hemoglobin, which is what we're born with, the lower the rate of polymerization. So they found this out a long time ago, that if you have more sickle hemoglobin, you're more likely to distort the red blood cells. And if you have more fetal hemoglobin, you're less likely to distort the red blood cells. So just think about that when we talk about how we decide to target our efforts for reducing the symptoms of sickle cell disease. But when you do have the polymerization and the elongation of the red blood cells, they can get really sticky, they can get really rigid, and they cause blockages and damage to blood vessels. And what happens with this is, if you can't deliver oxygen to your tissues, then you get something called ischemia, which is it's when you don't deliver oxygen to your tissues. But then an additional problem is if you release that blockage and you're able to deliver oxygen again, you get something called a reperfusion injury, which means that delivering oxygen to tissues that haven't seen oxygen can actually make things worse. And all of this over time can lead to what we call a progressive organ injury, which means that over time it gets worse and worse. And we think about sickle cell as kind of, you've heard the term vaso-occlusion, which means you have blockage of the blood vessel. Occlusion is blockage and vaso is blood vessel. But the other mechanism that we worry about is something called hemolysis. Oh, there's my wife in the background, she wants to listen. Hemolysis is breakdown of red blood cells. So this can not only cause anemia because you're breaking red blood cells, but there's a lot of molecules and important things inside the red blood cells that lead to inflammation, that lead to depletion of some other substances that keep the blood vessels open. So the combo of both of these mechanisms really leads to the really complicated nature of how we take care of sickle cell disease and how we think about it. And because of both of these mechanisms, the vaso-occlusion and hemolysis, this leads downstream effects that has multiple mechanisms. So you can have things like endothelial dysfunction. This is problems with the blood vessels getting really sticky. You can have something called sterile inflammation, which means that even if you don't have an infection or a bacteria, your body feels like it's inflamed from something. Hemostatic activation means that you're more likely to get blood clots. Oxidant stress means that you're having a lot of free radicals and circulating that can damage the tissues as well. Blood hyperviscosity means that the blood just gets sticky and thick. And then cellular hyperadhesion means that, again, it gets sticky and thick. Not all of these are happening to the same degree in all patients, and we have to be thoughtful about which of these we want to target, not just for identifying how severe a disease is, but also for how to actually treat sickle cell disease. Because if we only treat, part of it, we might be missing other parts of it that are important. I mean, I like this pyramid that I thought of when it comes to kind of how do we focus our attention in sickle cell disease? Because, starting at the bottom, we can think about, treating pain, right? Pain is the result of all of these things happening. But if we only treat pain, we're not really treating anything that comes above it. We're not treating this inflammation. We're not treating the hemolysis. We're not treating the, stickiness of the blood that's causing the pain. So that's why I think that in addition to treating pain, we have to be thinking about these other upstream things that are causing the pain, because they're also causing organ damage. And I don't want to just be treating pain and not treating organ damage as well. So the downstream effects are things like inflammation, hemolysis, thrombosis, which is blood clot formation. We can think about how to treat these, but we could also go a step further and treat the hemoglobin S polymerization, things that cause the red blood cells to form these elongation. And then of course, at the very top, we can think about the root cause, which is this mutation in hemoglobin in the beta globin. Treating that with things like transplant or gene therapy is kind of the ideal, but we kind of have to think, where are we targeting our efforts and what are we missing as a result of that? And there's a bunch of things that are not genetic that we can address too, right? Disease modifiers like other inherited hemoglobin disorders or things that make us more likely to polymerize the sickle cell, such as high altitude or acidity, exercise, cold temperature, things like that. There's a lot of modifiers. And so, I don't want to get bogged down in all the details of the pathophysiology, but this is just to describe to you that this is a really, really complicated process that has a lot of different features within it. And in order to effectively treat sickle cell disease, we can't focus on just one thing. We have to focus on all of it so that we're not missing a branch of the disease process. And this is just another depiction of just how complicated and interconnected all of the different kind of players are in sickle cell disease, and how targeting one of these things really needs to, it's a whole cycle. And if we just start at one place, we're missing everything else. And the severity of an individual patient's disease really needs to keep in mind all of these things. And when we come up with therapies, kind of what I'm going to talk about next, some of these are targeting each of these different mechanisms, but we kind of need to take an individual patient's case into mind when thinking about what cocktail of medicines or what combo of medicines are going to work the best. And you can see here that there's been a lot of medicines that have been tried. All of these that are unbolded have been medicines that have been studied for sickle cell disease. And unfortunately, most of them haven't really found a significant benefit yet. That's not to say that they can't be effective. But to date, there's only 4 approved medicines for sickle cell disease. If we had this talk 5 years ago, that number would have been just 1 medicine for sickle cell disease. And if we had this talk in the early 90s, that number would have been 0 medicines for sickle cell disease. So,
Question.
Yeah, sure.
So we're talking about the physiology portion. Is there ways that you guys have been able to consolidate the amount of targets that you actually have? So for example, instead of it being 50 to 60 ways that you can target a certain therapy based on somebody's physiology, do you have like main compartments, like how the graph looks right now? There's 4. So like a main, like this is going to definitely make sure that this set of people are going to be able to have this target and this target and that target. Do you guys have that now?
Oh my gosh, you're talking about like the holy grail here of getting, say, a blood test that tells me what does your sickle cell disease look like and which medicines are going to fix you, right? Like that would be such a goal for the future. And that's definitely one of my personal research interests, is understanding how can I take my patient in front of me, look at their blood, look at their symptoms, and tailor a treatment regimen that's going to be best for that person. I think we're getting there. I think we have some ideas, but of course, checking one molecule doesn't necessarily inform us about the rest of it. So I think we have to understand the whole picture and the whole body. And a lot of that has very little to do with the blood, right? A lot of that has to do with what my patient is telling me with their mouth and how they're feeling, which is, forget about all the blood stuff. That's the most important thing, is what is a patient telling me with their own experience. So I wish I had a good answer for you. I wish I could tell you there is a blood test out there that can define what a best course is. And I hope that that's going to be in our future. That's my goal, to really put in the resources and investment to do that. There are people who are really working on it, and
for sure,
for their efforts. Any other questions? Because I want to move on to talking about the drugs. So like I said, there's these 4 drugs that are available that really do target different aspects of this pyramid. And I put a little seesaw here because we got to balance the positive effects and some of the negative effects, and make sure that we're choosing the right, combination. And this is just to say we have a lot of tools in our toolbox, and we have to kind of understand the medicines, understand our patients, and put that whole story together to come up with a good regimen. So before I get to the discussion of the actual medicines and just tell you a little bit what we know about them and how we think about them when we talk to patients, I just want to ask any questions about just sickle cell disease pathophysiology, just the disease process itself, or anything that anybody didn't know about or was news to anyone?
Question. So in regards to, I made a mention of this in the chat. I think that a lot of pain to organs kind of goes unnoticed as to how it affects other parts of the body. And in some respects, neurotransmitters that are related to the brain's function. When do you guys start to realize, or is there any studies that show when sickle cell patients are going to possibly start having brain function issues that don't allow them to be as educated, or doesn't allow them to comprehend specific forms of communication information, or having trouble with learning abilities and so forth? Do you guys, is there like an idea as to when that starts to happen? Like, for example, if I get to like 12 years old and I have my first pain crisis and I'm having something that's really causing an issue with some of my organs, I may have specific situations where all of a sudden my trajectory and how my brain works is going to change, so to speak. Does that make sense?
No, that's a great question. And there isn't a single answer, because I think because sickle cell disease affects everybody differently, we have to just screen everybody. We have to address it from early on. And that's why it's so important to have a multidisciplinary team, not just a hematologist, right? But a social worker, a psychologist, a nurse, a school involved, all of those people to really keep track so that we can identify issues early, right? Because say a kid is having trouble in school. Could that be because of environment? Could that be because of sickle cell? The other thing that is really important is just because you have sickle cell doesn't mean that you can't be affected by other things that anybody can be affected by, right? Like ADHD or, other psychiatric issues. And of course, we need to remove sickle cell from the story and make sure that we're doing screening tests like the transcranial Dopplers to look at risk for stroke. We have to do MRIs to look for any kind of silent strokes that may not necessarily manifest with symptoms. But really, it's again, by listening to our patients, listening to and asking the right questions. How is your school performance? How is your work performance? Are there deficits that are subtle that you might not, a lot of our patients do such a great job compensating and functioning despite the challenges. It's like, it's so remarkable to me how,
resilient,
how much our patients do when we can really offer them help. And like Celeste said, one of our current goals is to really bring up neuropsych testing. So this is testing for really specific testing to identify, are there issues with thought process? Are there issues with processing? Are there issues with memory? And because I have a youth program that I work with currently in terms of like girls and boys that are between 3rd grade to 11th grade that play basketball. And one of the things that I'm constantly trying to remind them of is, energy, sapping of energy happens to affect how you think or how you're able to process something in real time. And as you guys get more tired and more tired, just understand that mistakes and errors are going to happen in the course of a game because your brains are not going to function as quickly as you want them to because of the fatigue. So, just transitioning that analogy into how sickle cell patients could be in that same situation. I get a kid that's 12 or 13 years old and he's been in a hospital 4 times out of the school year. His ability to just come back at full strength, like all the other kids, getting restful sleep at night is going to be so much more affected than normal. So you can't really expect this kid to be able to come in after being in the hospital for 2 weeks and then just, pick right back up where he left off. Sure. And that's something that's really detrimental to a lot of people. So sure, yeah. Now I want to get to these hand raises, but just to answer your initial question, the kids I worry about are ones who have severe anemia to begin with. Because I know that decreased oxygen delivery to the brain can be an issue when you have low hemoglobin, and people who have symptoms from early on, because we do know just from these natural history studies that early severe disease will lead to, more severe disease. Stephanie, you had your hand up.
Yes, I have a question and a statement. One, you mentioned that in the United States, there are about 100,000 people with sickle cell disease. My experience is that the numbers have been the same since the 70s. Do we have new numbers of how many people actually have it? To me, it seems like with more people identifying as African American or mixed race, that number shouldn't still be the same.
Right.
And other thing is that when we're talking about the drugs, hydroxyurea, please, please, please let patients know about its benefits for stopping end organ damage, because I had been put on hydroxyurea in like the 80s, but because the main thing that I was told was that it would decrease hospitalizations, when that wasn't happening, I stopped taking it. No one told me about the protection of your organs that it provides. Sometimes I think that medicine companies tell us what they think we want to hear. But if you actually ask in the community, not having hospitalization is just as important, as or not having extra protection for our organs is way more important than not having hospitalizations. Because as long as you can do things to keep us out of pain, and we can do everything else at home, then there's not an issue.
Yeah. No, I totally agree. Thank you for those points. And for your first point of like, why are there still so many people with sickle cell disease if, there's a change in the demographic of our population? One thing to note is that, there might be fewer people being born with sickle cell disease. I'm not sure if that's actually true. I feel like there's probably a similar amount, but people are living longer. And so, there's some people out there who are becoming the first geriatric sickle cell disease doctors. And I think that that's really wonderful. And so, that the longer lifespan that we're seeing right now in adults, it's certainly not as long as as it needs to be. And I think we have a lot of room to work on that, but I haven't heard updated numbers on how many people. And then to your second point, that is actually the point of what I'm talking about today. I'm so glad you brought that up, because of course, pain is something that I want to address. Of course, hospitalizations is important, but really treating treating sickle cell disease as the disease and not just the manifestations, not just the pain, not just the fatigue. I want to treat the disease so that all of your symptoms, not just pain, but your kidneys, about your heart, your lungs, your brain, all of those are treated in addition to pain, which hopefully will be treated along with that. Nadine, you had a question too?
Yes, I did. And I just want to piggyback on one thing before I get to my question, and that it was the statement that Stephanie made about that 100,000 people. Because the cultures are mixing, more and more people have the trait. More and more people are going to get the disease if we don't keep track of that particular type of information. And as far as I'm concerned, that's really key, because Antoine has the trait and his wife is Asian and their daughter has the trait. So, I think that there needs to be some research in that area with regards to that 100,000 people in these United States, because I'm certain that there's more than that. And then with the mixing of the cultures, more cultures are going to have the trait. So it's going to be all over the place after a while. But my question was, why is hydroxyurea at the top? Hydroxyurea was in the beginning. And it would seem to me as these new therapies come along, that should move further to the bottom, because that particular drug has a lot of clients have had a lot of difficulty with hydroxyurea, because hydroxyurea wasn't made for people living with sickle cell. That's a cancer drug. So, but it had obviously some components that would help people living with sickle cell. But it just seems to me that since we've come this far and we have all these new therapies in place. Hydroxyurea should be at the bottom, but I still hear clients say that they're taking, or they've been on Oxbryta and they're still taking hydroxyurea. So why is it that that continues?
Oh, that's a fantastic question. Thank you so much for asking that, because I think that really does speak to the purpose of what we're trying to understand here is what is the best combination or what's the best medicine, because just because they're new doesn't always mean that they're better, right? And each of these new drugs, I'll tell you about what they're used for. I don't think any single drug by itself is enough to treat somebody effectively with sickle cell disease. And the thing about hydroxyurea is that this is the medicine we've had absolutely the most experience with, right? We've been using it since the 80s, the 90s. And you're right, it wasn't developed as a sickle cell drug, but it has so many benefits that it's, even if we add on Indaria, Oxbryta, Adakveo, for almost all of our patients right now, because we know about the benefits of hydroxyurea, not just to reduce symptoms, but to preserve, it improves mortality. It makes your life longer. We still don't, we haven't switched from hydroxyurea to the others. It's more of like it's the backbone of our toolbox, and adding the others to hydroxyurea when you can tolerate it is the key. Of course, if people can't use hydroxyurea because they don't tolerate it or side effects, then it's great that we have these new other medicines to replace it and to have some benefit. But I don't think these new medicines, they work in very different ways that I'll tell you about. And so hydroxyurea is still the backbone of our therapy.
But just like Stephanie said too, she was taking that way back, and my son was taking hydroxyurea for a very long time, but after a while it became a problem for him. And just his whole process of digestion, having issues with his stomach, and he didn't want to take it anymore. So, you would, somewhere in the process, there needs to be either the dosage needs to be lowered, or I don't know what needs to happen. I just know that that particular drug, ultimately, after a period of time, people have difficulty with as well. Clients, right?
Well, let me tell you what the data is, and
okay,
and
great.
And let me answer this question about COVID. Actually, there's in the chat. I'm just curious, have there been data about how many persons with sickle cell have gotten COVID and how severe was it? There is data, and I apologize, I don't have it off the top of my head, but there have been substantial number of people with sickle cell who've developed COVID. And fortunately, in our experience across the Bay Area hospitals, we haven't seen severe disease from COVID. At least it doesn't seem to be more severe than anybody else who develops COVID. There is some suggestion that people with the SC genotype, hemoglobin SC, might have more severe disease than people with SS. But I don't know if that's really been kind of fleshed out. The other thing that we have to think about is how many of our patients with sickle cell disease have gotten vaccinated against COVID, and kind of what are the barriers to vaccination. I think that there's still more outstanding questions than there are answers, but if anybody else has knowledge on this, I'd love to hear. Still raised that from before? Okay. I know we're coming up on break time, so Antoine, feel free to just cut me off whenever you want to take a break. But I thought I'd just jump into the medicines and hopefully answer some of the questions about what these medicines are used for, what's our history of them, what data do we have to support their use, and in what patients might we think about adding them on. But before we get, sorry, go ahead.
I was at about 15 minutes till break, so we're
okay, great.
We got enough time.
Sounds good. So briefly about transfusions, which of course is not a medicine, but it's a treatment. And like I said, the goal of this talk is to discuss disease-modifying therapies, the things that change the actual pathophysiology, change the disease process of sickle cell disease. So of course, transfusions are used in many, many situations in sickle cell disease. And the goal is to improve your ability to deliver oxygen to your tissues by increasing your hemoglobin. But more importantly, it's to reduce the amount of sickle hemoglobin in the blood so that you don't have as many cells that are distorted. And this can be done either by a simple transfusion, just a regular infusion of blood through the vein, or an exchange transfusion where blood is removed from the body and replaced with normal blood. This can be done manually as we do at the general, but can also be done through this machine here called an apheresis machine that is automated. And we do this in Oakland. And sometimes it's done in the hospital if you're really sick. For sickle cell, actually, the only group of patients who we know it has a clear benefit that it's absolutely, we refer patients for a chronic transfusion regimen, like monthly transfusions, is if we know that you're at risk for stroke. Either you've had a stroke before, or based on your transcranial Doppler, the imaging study that you can see this young man having here, that you're at risk for stroke. Of course, there's many, many other reasons that we do transfuse patients, such as symptomatic anemia, pregnancy, really frequent recurrent pain, acute chest syndrome, priapism, and some other indications. But all of those don't have as much evidence backing their use. That's not to say that we won't use them. And the reason why we don't transfuse everybody, why we are a little bit hesitant, is because there's of course risks associated with transfusions, such as transfusion reactions, like allergic reactions, antibody formation, such that you're limited in the type of blood that you can get, and iron overload. Of course, every time you get a unit of blood, you're getting more iron in the body. And so in the absence of stroke risk, if we feel like you're not at a high risk for stroke based on the imaging that we're able to do, it's really important to optimize other medicines prior to initiating transfusions. But now let's get into the actual medicine. So this is hydroxyurea. You hear about it all the time, and it's just this dinky little molecule of like a few atoms. And it has a couple of other names. The medication name is called hydroxycarbamide, but we also call it Hydrea or Droxia, HU. Like Nadina mentioned, it's a really, really old drug. It was actually discovered back in the 1860s. And since the 1960s had been used as a cancer medicine for both solid tumors and leukemia. It was FDA approved in 1967 for cancer. This is almost never used anymore in cancer. I'm also an oncologist, and it is such an old medicine that is no longer used as a cancer drug. And when it was used as a cancer drug, it was used at very, very high doses. That is nowhere near what we think about for sickle cell disease. But people in the 1980s had these two simultaneous discoveries. They found that, as I mentioned before, people with elevated hemoglobin F or fetal hemoglobin levels with sickle cell disease had a milder course. They had less severe symptoms, and they had a just better outcome. And at the same time, they found that some of these chemotherapy medicines like hydroxyurea and some others actually increased your hemoglobin F production. And so they thought, hey, if this medicine is increasing hemoglobin F production, and we know F levels are protective in sickle cell disease, why don't we try to study this for the use in sickle cell disease? So that led, and this is just one of those slides that I think is here if you want to look at it, but we don't really know this precise mechanism of hydroxyurea, but it really has a lot of significant benefits. It induces this hemoglobin F production, so you have more fetal hemoglobin circulating. But at the same time, it kind of decreases some of these other factors in your blood, like white blood cells and platelets, which, if elevated, are associated with more severe disease. It also reduces the stickiness of your blood cells to the blood vessels. It decreases the amount of hemoglobin S, and it can kind of keep the blood vessels. It's a really amazing medicine, actually, that has a lot of effects that we don't quite understand, but with our long experience with it, know about its safety and its effectiveness. So it was first studied actually in the 80s, and the first publication was in 1992, showing that before we look at how effective it is, the first thing that we always have to do is figure out whether it's safe. And so they studied this in 32 patients and showed that hydroxyurea did have an increase in hemoglobin F production without any significant other safety issues. And this led to a much larger trial called the MSH trial, or the multi-center study of hydroxyurea and sickle cell anemia trial, which is kind of our landmark. It's probably one of the most important studies that has been done in sickle cell disease. This was a phase 3 double blind, so the patients didn't know whether they were taking a placebo or hydroxyurea, and neither did the doctors. And it was randomized. So people with severe disease, sickle cell disease, SS, with lots of pain crises, were randomized. And what they measured were things like how many pain crises did people get, the time to the first pain crisis, how often did people get acute chest syndrome, number of transfusions, hospitalizations, and they also, of course, looked at all the labs. And the results from this were kind of amazing. And actually, the study was stopped early. It didn't finish because the benefit of hydroxyurea was so impressive that it was unethical to continue with that placebo arm. People who weren't receiving hydroxyurea, it was unethical to not give them hydroxyurea because we knew clearly what the benefit was. And just to lay out some of the benefits here, it had a lower incidence of painful episodes, 2.5 versus 4.5 crises per year. There was a longer time to the first pain crisis and the second pain crisis. There were fewer transfusions, lower acute chest syndrome. You had a higher hemoglobin, you had higher hemoglobin F levels. And really you can, there's the laundry list of just so many benefits. And these were all achieved despite people not actually, most of the patients didn't really get up to the maximum dose. These graphs on the right are just showing the event rate, so how often people got pain crises, comparing the placebo, which is the sugar pill, and hydroxyurea. And you can just see that there's a clear difference between those who got hydroxyurea and who didn't in terms of how often they were getting pain episodes. So this is probably, in my opinion, one of the most important studies in sickle cell disease when it comes to this is the first time we had anything that made a big difference for not just pain, but for organ preservation. And so this led to the approval of hydroxyurea in 1998 for use in sickle cell disease in adults. And later on, we did trials in children that not only showed that it had the similar effects of kind of reducing the severity, but this baby hug trial, the baby hydroxyurea group trial, actually was trying to look at how can we prevent any organ dysfunction, prevent pain episodes in kids even as young as 9 months. And all of the studies really show very, very similar results, that not only is hydroxyurea safe, but is effective in reducing complications and preventing complications. And then of course we think about the long-term effects, right? One of the benefits of hydroxyurea is that we have decades of experience with it. And the MSH trial, that landmark trial, had a long-term follow-up study of people who had been on HU for greater than 10 years. And there is a benefit in mortality, which you can only really tell over a long period of time. So that's one of the limitations to some of our newer drugs, is they're all new, right? We don't have long-term experience with them, but we do have it with hydroxyurea. And this is, a really difficult to look at image, but it just shows that people who've been on hydroxyurea for a long time are much more likely to have a better clinical course.
What does hydroxyurea, how does that affect the fetal hemoglobin? I missed that, I think.
We don't have a great answer for that. We know what the target is. It's this protein called ribonucleotide reductase, but we don't quite know how to link that to the induction of fetal hemoglobin. It has to do with the regulation of the genes and what's expressed, because fetal hemoglobin, we're all born with fetal hemoglobin, but it gets shut off when we're between 4 and 6 months of age, and we transition to our normal adult hemoglobin. And so somehow hydroxyurea kind of reverses that shutoff mechanism and it turns it back on. It turns on to produce fetal hemoglobin. And that's actually one of the targets of like our gene therapies and other medicines too, is go back to our fetal hemoglobin, which is safe and protective.
Yeah, okay. Because fetal hemoglobin is that good stuff.
It's great.
Right, that's the stuff you want.
You can think about it as it holds on to oxygen a little bit better. If when we're inside our moms, if we had the same ability to bind oxygen as our moms, then our mom's blood wouldn't give it to us, right? So we need a stronger hemoglobin than our moms so that we can collect the oxygen from them, because our moms are giving us oxygen when we're growing inside of them.
Right. Okay.
So we don't need it. Most of us don't need it when we are outside of our moms, but in sickle cell disease, it is protective because it holds on to oxygen better.
Yes, absolutely. Okay.
So this is a slide that I can tell you my experience about, and I can tell you what I know about the side effects and what people tell me about their experience with hydroxyurea, but this is where I really need to hear from people who take hydroxyurea. And because what I know from these studies is that it's well tolerated. There's really few short-term side effects. Most people don't really have any major side effects, and people tend to tolerate it pretty well. And there's this question of, this is a cancer drug. Does it cause cancer? And we've never had any clear evidence that it causes cancer. I can't say for sure, and I won't say that this doesn't cause cancer, right? Like that, there is no evidence to say that either. But my concern about hydroxyurea and its risk for cancer, which I think is a real major concern I hear from a lot of my patients, is something I think that the benefits of hydroxyurea are far, far outweighed by the potential risk for cancer. And, like you mentioned, this is a cancer drug, but it wasn't a very good cancer drug. And I think that the benefits that we're seeing in sickle cell disease at this much lower dose than what was used for cancer should really make this be thought of as a sickle cell drug that used to be used for cancer. I don't think it really is fair to call this a cancer drug or a chemotherapy drug, even though that historically is what it was. And the other thing I think about is we don't have a lot of great evidence about its safety during pregnancy or when you're trying to get pregnant or during breastfeeding. Our current practice is to recommend stopping hydroxyurea when both men and women are interested in getting pregnant or are pregnant. But there's many people and many studies have shown that people have gone through full pregnancies and remained on hydroxyurea and haven't had any problems with the baby. I think that we just don't know enough to make a recommendation on this yet to say that it is safe. And so we just don't take chances here.
Well, I just have to say too, Dr. Vissa, that my son had gastritis. He had alopecia and nausea. A lot of these things, a lot of these that are here listed are some of the effects that my son was experiencing when he was taking it.
For sure. I mean, this chart here is useful kind of, but who cares what 10% of people feel, right? When I'm talking to my patient, that's just one person. And so if they feel it, 100% of them feels it. So this is just the things that I counsel patients on, that for the most part, it's well tolerated, but some people do feel that the skin and nail changes that they experience are too much to handle, that their nausea or stomach issues is a problem. And then of course, from a medical standpoint, they can reduce your white blood cells and your and put you at risk for infection. And so those are things that we really need to monitor and watch for.
Okay, I got one other thing I want to say. My son also wound up on dialysis. So now, because he had renal failure. So does hydroxyurea, or does any of that come into play with regards to the kidneys and the functionality of your inner organs?
And that's a great example of how hydroxyurea is intended not just to reduce symptoms, but to preserve organs. And so, my goal is to initiate hydroxyurea early so that the kidney function is preserved and we don't end up on dialysis. Say we do have a patient who is on dialysis and we want to make sure that they're, we're optimizing their sickle cell to make sure they're as healthy as possible, even if they are on dialysis. Hydroxyurea can be used in those patients and is a really important medicine to, keep them as healthy as possible.
Great.
And of course, in consultation with the kidney doctors, who are going to be very important in that.
This is great. Thank you. This is great. My husband has a question.
I have a question.
Of course, yeah, please.
Okay.
Last question. This will be the last question.
These drugs, treatment for sickle cell patients needed a couple of parts, not just one. Is that true, what I heard there?
Mm-hmm.
Okay, then what other drug is suitable to assist or to pair with hydroxyurea based on the ones that you outlined in this session?
Yeah, this is a great segue to our break so that we can talk about the other drugs coming up after. How's that sound?
That's fine with me. Thank you.
All right. Antoine, is now a good time for a short break?
Yes, sir.
Okay.
Yes, sir.
This is
more
really
exciting, fun stuff coming up soon.
This is really good. Madhav,
So with that being said, we are going to go to break for the next 5 to 6 minutes. There should be in the thread, Nadina, if you can, we need the link to the survey. Everybody seems to be giving some really good feedback on the chat about this being great information for us to either have or talk more about. So if you guys want to make sure we get these slides in your inbox so that you can take a look at them and refer to them, if you guys have an opportunity to speak to this group later, please fill out this survey as best you can. Nadina, please advise the group by unmuting your mic when you're ready to let them know that the link is available for them. We are officially on break.
Okay, the link is in the chat box.
Please send again because I don't see it.
Yeah, I don't see it either. Thank
Oh,
you.
wait a minute here.
So based on all of this data that I just presented, the National Heart, Lung, and Blood Institute, which is the division of the NIH, which is responsible for kind of management of sickle cell, recommends initiation of hydroxyurea in all children with hemoglobin SS or S beta 0, starting at 9 months, and all adults with 3 or more vaso-occlusive episodes a year. So our practice in Oakland and as well as in San Francisco is really to kind of offer hydroxyurea to anybody who has sickle cell disease SS or S beta 0. If people have SC or S beta plus or other genotypes, really we kind of discuss the pros and cons of being on hydroxyurea, and if we're managing patients who have a lot of pain or have a lot of other symptoms or are worried about their organs, then I'll definitely discuss it with them. We have actually considered hydroxyurea in even younger patients, even younger than 9 months, for little babies if they have severe pain, if they have to be hospitalized or something. But we know about the safety of hydroxyurea in kids even as young as 9 months, and so in our pediatric practice, this is something that we really emphasize early because, boy, wouldn't it be great if we just prevented all the problems to begin with instead of dealing with them once they showed up. Of course, there are some difficulties to hydroxyurea that, despite the clear benefits and despite the fact that it's relatively well tolerated, many patients either aren't on hydroxyurea or are not on optimal dosing. So there's a lot of reasons for this. One is clinicians, their providers have clear knowledge about the benefits, about dosing, about how to monitor, and about how to counsel on side effects. For little kids, the oral solution's a little bit tough to come by, so the pills might not necessarily be useful. Of course, we think about the concerns about, predisposing to cancer or predisposing to like fetal abnormalities or other side effects. There's a lot of concerns out there that may be true, may not be true. And I think there's a lot of misinformation that we hope to clear up. It's a burden to take a daily medicine, right? To get your labs checked every couple of months, to have come to clinic frequently to get your labs checked. It's not a very easy medicine to manage. And of course, we understand that there are challenges that our patients face that make hydroxyurea not a really easy medicine to take. And people might not necessarily feel a benefit right away, especially right when it starts. They might be feeling more side effects, not have a big change in their pain experience or frequency of hospitalization right away. And it might take time either to feel an effect or to get to the right dose to feel an effect, because we do adjust the dose based on your lab parameters. So, people who start the medicine and don't really feel a big difference, because it's not like a pain medicine, right? You don't take the medicine and feel better right away. It can be a little tough to remember to take it or to feel motivated to take it if you don't really feel a clear benefit. And then in this country, especially with insurance, coverage and cost might be an issue. We haven't run into too many problems with that, but I don't know if anybody on the call has had issues with hydroxyurea in terms of coverage or access. This is more for prescribers, but basically it's available in a bunch of different capsules and liquid, and the dosing is pretty standard, but we do try to maximize to what's called the maximum tolerated dose for patients. And if patients do have some kidney problems, we start at lower doses because it's cleared through the kidneys. So if you can't clear it well through kidneys that aren't working as well, you don't need as much. And when you're hospitalized, it's usually okay to continue hydroxyurea unless your white blood cell count is really low or you have kidney injury or another serious infection. This is, again, mostly for prescribers, but the reason why we check your labs all the time when you come in on hydroxyurea is because we're monitoring all your blood counts, not just your hemoglobin, but your white blood cells, platelets, reticulocyte count, hemoglobin F. And all of these need to kind of be within a safe range, and we increase the dose if it's still safe, and we cut the dose back if we see that the white blood cells especially are going low. And this is the reason why we are such pests about getting into clinic when you're on hydroxyurea. And I just wanted to mention this thing called the maximum tolerated dose. So this is basically, we try to go up and up and up on the dose of hydroxyurea to achieve its maximal effect without causing any significant side effects. And this can be variable from patient to patient. So everybody needs to kind of develop their own maximum tolerated dose. And this depends on things like your kidney function, your liver function, how, there's other genetic things that can play a role into this. But this is why we are checking your lab, and just telling you this to tell you why we're checking labs so frequently. And this is an interesting study that was done in in Uganda, I believe, where they were looking at, is it worth it to be like so fussy and such a pest about this and to get you into the clinic all the time to check your labs? So they looked at 200 kids in Uganda, and they randomized them either to receive a fixed dose, so everybody just got the same dose of 20 milligrams per kilogram of body weight, or there's other cohort where they were checking labs and they were increasing the dose based on their lab parameters. And the idea of this was like, okay, well, it takes a lot of resources. It's really time intensive. It's kind of a pain to get people into clinic, check their labs, change their dose, pharmacy, blah, blah, blah. Is it worth it? Versus just if people were taking hydroxyurea, we weren't checking, we were just giving them the medicine and seeing if it helped. They found that in the group that had, we were more pests about it, where we were changing the dose, they had a much higher increase in their hemoglobin and a lower chance of sickle cell related complications without any added side effects. They weren't like having more side effects. Whereas the patients who were receiving a fixed dose were more likely to be hospitalized, more likely to be in pain. And so really the kind of resources were being used anyways. And this helped to, this is just that's something that I think about all the time, where I'm saying it's really worth it to be fussy about this and to make the changes to maximize this effect so that we're really getting our bang for our buck here. And then there are reasons to discontinue hydroxyurea. One is if cytopenias means your low blood counts, your white blood cells or your platelets are too low. If your kidney function is getting worse on hydroxyurea, then it might be a reason to stop it. If you're having really bad side effects like skin issues, pancreas issues, other side effects that you're telling me about that impair quality of life, like hair loss or skin changes, those are reasons to think about either cutting back on it or stopping it. And of course, like I mentioned before, we counsel both men and women of childbearing age who are trying to conceive or who are currently pregnant or lactating to hold hydroxyurea during that period and to resume once you're done breastfeeding. We've had some patients actually need to go on transfusion regimens to kind of support them during pregnancy, and even men when they're trying to conceive, in order to avoid hydroxyurea but not get more severe disease. And then, of course, there's a bunch of things to do if hydroxyurea isn't helping. First thing to do is to, assess whether you're taking it every day, because you need to take hydroxyurea in order for it to be helpful. But there are a handful of patients that even if they take it every day as prescribed, it still doesn't help as much. So it's important to counsel people on the importance of daily dosing, and make sure you give some time to see a response, at least 6 months once you achieve the maximum dose. And to continue even if your blood counts aren't really reflecting it. But if you're really seeing no clinical benefit, your blood counts aren't really changing, it's probably okay to stop hydroxyurea and try other drugs if you really are convinced that it's not helping. And so here are just my final thoughts on hydroxyurea, and I'll spend a little bit less time on the other meds because we don't know as much about them. But this is the drug that we have the most experience with in reducing the severity of symptoms and reducing the organ complications. It's a really complicated drug that has a lot of mechanisms of action that target many of those pathways in sickle cell disease. So it's not just targeting one piece of the puzzle, it's targeting many of those pieces. And importantly, it's generally very safe and only a few people report serious side effects. But what's really important is that we adjust the dose and ensure that we're optimizing it and to get a maximal effect. And just to re-emphasize, I put it twice here, this bullet point, that it's not just to reduce symptoms, but it's used to prevent organ injury. So based on all of this, and we have a couple of our warriors and advocates here. I'd love to hear kind of what you've thought about how you've been talked to about hydroxyurea, and what your experience has been, side effects or benefits, and whether if you're talking to other people with sickle cell, if you'd suggest it.
No, this is Stephanie again. Excuse me. I think that when I found out about the end organ damage protection that is available with hydroxyurea, the first word that came to mind is angry, because we constantly get people telling us the things they think are important for us instead of telling us what it does and leaving it at that and letting us decide what is important for us. Given the amount of years that I didn't take the hydroxyurea, I'm sure there's been significant organ damage, and that could have been prevented by just stating the facts and not picking and choosing which ones were relevant for me. So that is an issue I have with how drugs are presented to patients. And as far as the side effects, the one I have is the creatinine one. Other than that, I don't have any side effects.
But it impacts your renal function, your kidney function.
Mm-hmm.
Okay. Great. Anybody else have any side effects that I didn't mention, or that really kind of are limiting their ability to maximize hydroxyurea use? Either personally or that people that they know? Yeah. No, Stephanie, thank you for bringing that up. Oh, go ahead, please.
I know that when I had, I don't know what it's called, but I had this open sore on my foot, and taking the hydroxyurea around that time was making it hard for my ulcer, I don't know what it was, to close up. So I had to stop taking hydroxyurea in order for the sore to close up.
So it was impairing your wound healing. Got it. Yeah, because
Yeah.
we need white blood cells to be effectively working for wounds to be treated. So yeah, that's a really good point. Thank you. Karen, did you have a comment?
Yes, I just wanted to share that my son has been on hydroxyurea since he's a kid, maybe 11, at least since I've known him, since 11. But just this year, he was up to 3-4 capsules, I guess. But just this year, he had a situation where he had really low red blood cell count. And so the advice was to just stop for a while, and he had to get some blood transfusion, and then try and then see what his blood count was. And then after a few weeks, a couple months, he's back on it now with half of the dose that he was on.
Exactly. Yeah, no, thanks for sharing that. And this is exactly, the goal of hydroxyurea is to make your blood cells healthier, because normal red blood cells live for something like 90 to 120 days, whereas sickle red blood cells only live for something like 10 to 20 days. And so that's why the hemoglobin is pretty low in sickle cell disease, because you're breaking down those red blood cells faster than you're able to make them. But unfortunately, with hydroxyurea, you are kind of stopping the production of some cells and relying on the fact that the cells that are in your circulation are healthier and living longer. So that is kind of how you raise the hemoglobin. You always think about what are you losing and what are you replacing with new production. So unfortunately, sometimes with hydroxyurea, we do see that we're shutting down the bone marrow a little bit more than we need to, and that's a good reason to back off on the dose. And for your son, it sounds like the maximum tolerated dose is lower than what we went to. And we do see this sometimes. We're going to have to push the dose and breach those parameters before we pull back and make sure, and hopefully our counseling also includes things to watch for, like fevers or fatigue, other symptoms of low blood counts, so that we can get attention right away. Thank you for sharing. All right, well, you know, there's a lot to talk about for hydroxyurea, and I welcome any other comments. But as we mentioned before, this has been the only drug we had for such a long time until 2017, when we had new drugs available. And because this medicine works to target so many of the different pathways causing severe disease in sickle cell, it's still such an important backbone for our therapy. And the new 3 drugs I'm going to talk about kind of target different pathways, and for those reasons, you know, they add to hydroxyurea. They don't replace hydroxyurea because they have different mechanisms. And I hope that I can give you a little bit of information about what we know about them, and just be straightforward that what we know about them isn't a lot. We know just from our couple of years of experience, and I'm looking forward to many more years of experience so that we can really form, you know, I can give you this many thoughts about hydroxyurea for these others. So the first drug I wanted to talk about is called Endari, or L-Glutamine. L-Glutamine, you know, you can go to like GNC or Trader Joe's and get glutamine. It's just an amino acid that is present in lots of things. But Endari is kind of the pharmaceutical grade. It's made by the drug company. And so we know it's kind of a purified form of L-Glutamine and doesn't have any other stuff in it. So glutamine, like I said, is just it's an amino acid. It's a regular kind of compound. It's not really a synthetic medicine. It is relatively natural. But what it does is it has an antioxidant capacity. So it helps. This is just a really complicated biochemical pathway, but in sickle cell, we're kind of constantly under oxidative stress, creating radical reactive oxygen species. And the goal of L-Glutamine, even though it's not totally straightforward how it works, is that it acts as kind of an antioxidant in our blood. And this was trialed in 2018. It was published in the New England Journal of Medicine, a multi-phase randomized control trial. Again, some people got Endari and some people didn't. About 230 patients, both kids and adults. And it was only studied in S0 patients who had at least 2 pain crises in the previous year. And the primary thing that they were looking at is number of pain crises in just about a year period. They also looked at the number of hospitalizations, sickle cell related events, changes in hemoglobin, things like that. And this, just I want to be transparent, was funded by the drug company Emmaus Medical. And they found actually that the people who got L-Glutamine had on average a lower number of pain crises. It wasn't a profound difference by any means. In contrast to the people who got the sugar pill, they had 4 episodes on average. The people who took the drug had 3 episodes. Had about 1 fewer hospitalization. They had a little bit longer time to the first pain crisis and second pain crisis, and they had a lower incidence of acute chest syndrome. These P values here are just the statistical significance. All of these were significantly different, even though the numbers themselves aren't like that impressive. And for people who were also taking hydroxyurea, there seemed to be kind of a combined benefit of, so the people who were on hydroxyurea seemed to do better than those who weren't on hydroxyurea when they were getting L-Glutamine. This is just kind of similar graphs to see how, you know, what proportion of patients over time were developing symptoms. And it looked like there, you can see that there's kind of a gap between these two. The people who were taking L-Glutamine tended to have, it tended to happen a little bit less frequently than the people who were not taking L-Glutamine. Interestingly, in this study, they of course look at the side effects of people taking the drug and not taking the drug. And they found that more people in the group that was taking the sugar pill had side effects than the group taking the actual medication. And the side effects that they report were typically pretty mild. Some people had nausea and some people had a little bit of pain. It was tough to tell whether that was because of the medicine or if it was just the baseline sickle cell pain. But for the most part, it's really well tolerated. And important to know that this was not studied in women who were either pregnant or breastfeeding. And so we can't say that it's not safe, but we can't say with certainty that it is safe. We just don't know. It is a powder form. And for those of you who are taking it, you can kind of share what the taste and things are about it. And right now it is FDA approved for sickle cell disease. We don't have approval for the kind of generic form, the L-Glutamine that you can buy at GNC or the supermarket. So Indari is the only form that's approved for sickle cell disease, but it's only available through specialty pharmacies. So it's an option to try, over-the-counter L-Glutamine if this is too expensive, or if you don't want to go through the insurance hoops, but we don't know for sure that those are going to be effective. And we've used this in kids as young as age 5 and older. It's been studied in those populations. We typically say you should mix it with water, and depending on what your weight is, it's either 1, 2, or 3 packets. And we don't really need to monitor this. It's not like hydroxyurea where it changes your blood counts or anything. And so we don't need to really monitor its effect. So these are just my thoughts on Indari, that it has kind of a modest decrease in the number of pain episodes. And we don't have long-term data on this. The cost might be a little bit more. It is definitely a much more expensive medicine than hydroxyurea. And there's concern that there might be some interaction between, non-Indari, the like other formulations that you can get at the store, and hydroxyurea. So I don't always advise people to just get L-Glutamine somewhere else. I think that if we're going to try L-Glutamine, we should try Indari. And to me, it seems kind of gross, just taste-wise. I haven't ever tasted it. I don't know if anybody on the call has taken it. It's the idea of mixing something in water isn't super appealing to me, but I'd love to hear anybody's thoughts on here who's tried L-Glutamine. Yes, Stephanie, go ahead.
Thanks. My thing is it's a texture issue. I haven't tried it in water because it's difficult to do in like juice or anything. But I found that if I mix it with like applesauce or a little bit of something like carbonated water, then it is a little bit more palatable.
Okay, great. Yeah. When I talk to patients about this, I certainly feel like the safety and the side effects from it are so minimal. Like it's a really safe drug and people tolerate it really well. And so why not try it? But I try to make sure that I'm transparent about the fact that I don't expect it to be like a game changer in sickle cell. You can even sense my tone comparing how I talked about hydroxyurea to Indari. I think it's a good drug and I think it's definitely worth trying. But I don't expect this to be like, if Indari is the only thing that's taken, first of all, we don't know about its long-term effect when it comes to preserving organ function, which is of course important. But if it helps with pain, I'd say that it's a great option that we now have. Anybody else have any thoughts on Indari or L-Glutamine? Can I ask how has it been? Sure, yeah, please.
Okay, what is the relationship between oxidation and inflammation?
Yeah, so in sickle cell, we do worry about, because of how inflamed the body gets, it can be multifactorial. It can be because of a bunch of different reasons. But when the cells are breaking down, when there's a lot of kind of oxygen being transferred, then it can create these free radicals that injure the blood vessels, injure the blood cells, injure the organs. And a lot of that has to do with depleting these kind of antioxidant molecules that we have in our bodies already. So our bodies are trying their best to fight this oxidative damage, but it can only keep up as much as it can. So the point of the drugs like Indari is to kind of support the body in doing its antioxidant effect, because it's just using up all of its resources already when the body's inflamed. Okay,
now on a personal level, I don't have sickle cell. I have no organ problems. What is you think it'd be a good idea for me at my age to take L-Glutamine?
Maybe. I mean, I like to think about natural remedies too. So things like berries or other antioxidant foods, and of course, avoiding oxidant stress, not eating a lot of like red meats and, other toxic things like smoking, for example, can cause a lot of oxidant stress. So just general health, I think, is a good idea. But I don't know if this has been studied, L-Glutamine in patients without sickle cell disease.
Yeah. Okay.
So I don't know. I don't have a good answer.
I have
I can't imagine it hurts, but...
See, I have arthritis and inflammation. I was wondering how that could help in.
I wonder, yeah, it's possible, but I don't want to promise it.
Okay,
I don't think it's
just
really
a question. Thank you very much for the information.
Sure. I'm going to move on to the next medicine. I know we're kind of coming short on time, so I want to make sure I get through everything. The next medicine that was recently approved is called Oxbryta or Voxelitor. Oxbryta is the brand name by this company, Global Blood Therapeutics or GBT, and Voxelitor is the drug name. And this is actually the first medicine that was created specifically for sickle cell disease. So this targets specifically sickle hemoglobin, and it really doesn't have a use in other patients. This is for sickle cell disease. In terms of what it does, this is a small molecule, so it's just this protein here, and it binds to sickle hemoglobin. It binds to actually the other part of hemoglobin, the alpha globin, and it prevents it when oxygen is not bound to hemoglobin from forming these long strands. So we think about this as an anti-sickling drug. What it does is actually it increases the affinity of hemoglobin to oxygen so that it holds on to oxygen a little bit more strongly and reduces its likelihood of sickling. The other nice thing is that this is an oral medicine and it gets distributed into the blood pretty quickly. And really the main point is to reduce sickling, reduce hemolysis. And before we tried it in people, we of course tried it in the lab, and it showed that it delays polymerization of hemoglobin. It increases the half-life of red blood cells, so it means that they just live longer, and it reduces hemolysis, so the cells are not breaking down. And the early trials actually showed that they had a similar effect in patients, and it was well tolerated. So this led to the HOPE study, which was the kind of largest trial that was sponsored by GBT a couple of years ago. And some of my mentors here, like Dr. Vichinsky and Dr. Hoppe, were the investigators on this. This looked at patients as young as age 12 with all sickle cell genotypes. And they were randomized to either receive a sugar pill, placebo, or Voxelitor at 2 different doses. And if people were taking hydroxyurea, that was allowed too, as long as they were on a stable dose. And they enrolled about 280 patients. And what I think is really important about this drug is that when they studied it, the outcome that they were looking at was actually not pain or symptoms. It was just an increase in hemoglobin. And I'll tell you why I think this is important. We know that anemia by itself, just having anemia alone, is a risk factor for things like pulmonary hypertension, kidney injury, stroke, and actually mortality, death. Low hemoglobin is a risk factor for all of those. So the goal of this drug is to raise the hemoglobin to prevent this long-term injury. Right now, we actually haven't, with this drug, seen a really kind of significant change in pain episodes. I think our patients who take it are reporting just to us that they have had a slightly lower incidence of pain, but this was not developed as a medicine to reduce pain. This was medicine that was developed to reduce sickling, to reduce anemia, and my hope is that this is more of a long-term disease protection rather than a short-term disease protection. Of course there are, and in the study, they did find that there was a significant increase. Most people had an increase in hemoglobin of about 1 gram. And you can see here, this is just each individual patient. Most patients had a pretty significant increase, even above 1 gram, compared to the placebo, where some patients had a slight increase, some patients had a decrease. There wasn't really a major difference. But 59% of the patients who received this higher dose of Voxelitor had a hemoglobin response, that their hemoglobin went up. I do want to talk about side effects because, unfortunately, this drug has had, I think, in our clinical use, more side effects than were reported in the trial. So in the trials, many patients did report headaches, diarrhea, abdominal pain, and nausea. And I hear from a lot of patients that the abdominal pain and diarrhea is a really, really important factor. And it's a lot of my patients have had to deal with the diarrhea, and it's causing problems. So just briefly, for prescribing purposes, it was approved in 2018 for patients over age 12, and actually just end of last year, the approval is extended down to age 4. It's available as tablets, but they recently just released an oral suspension as well. For people who have kidney problems or who are on other medications, we might need to adjust the dose a little bit, but it's typically standard dosing, and the dosing is here. And this is only available through the specialty pharmacy, so we can work with you to prescribe it. And again, it wasn't studied in people who are pregnant or breastfeeding, and so we don't have safety data. But we do know that it can be administered with hydroxyurea safely, and there might be an additive benefit. We don't know really yet what the kind of combined benefit of it with L-Glutamine or crizanlizumab, which I'll talk about next, is, or for patients on transfusion. That's not to say that we shouldn't use it in those patients. It's just that we don't really have data to understand its kind of additive benefit. So here are just my thoughts about Voxelitor. This is the first drug that was approved specifically to target a mechanism that we know to be affected in sickle cell disease, rather than kind of dealing with the downstream effects, the consequences of sickling. And I think about this for patients who have a low baseline hemoglobin and more severe disease. You know, if somebody's doing really well and their hemoglobin is on the lower side, but they're otherwise, you know, organs are functioning well, they're not having a lot of pain, I might not necessarily add a new drug. We'll talk about it. I certainly want to offer it to patients who are doing well, but I think about this for people who have symptoms from anemia or have a really low hemoglobin that I worry about leading to long-term effects. There's this theoretical risk that we don't have to get into here too much, that, you know, this medicine is increasing hemoglobin affinity for oxygen. So could it be that it's holding on to oxygen too much, right? Because if oxygen is on hemoglobin but can't get delivered to your brain or to your heart, then is it really causing any improvement? And so far, the clinical trials haven't shown that oxygen isn't being delivered effectively, but that's certainly a safety concern that some providers have, that, you know, are we impairing oxygen delivery to the brain? And, you know, what's the safety of that? We don't have long-term safety or efficacy outcomes. You know, it's only been used for a couple of years, so time will tell, you know, what the long-term effect of this medicine is. But there are, you know, other studies going on. There's this Hope Kids 2 study looking at stroke risk change for kids with Voxelitor. And I think that it's going to be interesting to see how this evolves in the future. We don't really know how Voxelitor is affected by transfusions, so that's something that we got to investigate as well. And I put these money signs here because this is an expensive medicine, but would love to hear for those of you who've tried Voxelitor or who've heard about Voxelitor, kind of how you've been counseled on it and what your thoughts are. And of course, if you are taking it and if you tolerate it or don't tolerate it.
Not very many people have taken it.
Yeah, it's relatively new. And like I said before, optimize hydroxyurea before adding a new medicine, because of course, if hydroxyurea isn't effective because it's not being taken every day or because you have side effects from that, I'd rather kind of fix that problem rather than adding on a new medicine. Because, you know, I don't want my patients to be burdened by a lot of pills. And if it's tough to take one, why would I add another one, right? Karen and Bethany. Karen, you want to go?
Yeah, I was just going to say, Devon was recently prescribed. How do you say it? Right. And but he hasn't started yet because of the incident where his the incident where his blood count was so low that he had to go off of hydroxyurea for a little bit, and then he's back on, and it seems like he's stable, but I think they're going to wait for just a couple more weeks before trying the Oxbryta. But so this is very helpful.
Yeah, no, and that's a good thought. And of course, this is a medicine that our goal is for this to be kind of long-term organ preservation. So starting it today versus a month from now, I don't think is a huge deal. We want to make sure that he's in good shape to see a benefit.
Okay, thank you.
Sure, Stephanie, go ahead.
Sure, just one more thing. So Devon has been a smoker in the recent years, and but he knows that it's not good. He's maturing a little bit, and he knows it's not good. Yeah. So he asked for some medication to quit smoking.
Great.
And it was covered under his insurance, probably because of his sickle cell. I'm not sure, but we haven't tried it yet. But that's going to be kind of another thing we're going to try.
That's fantastic. Kudos to him. And just, back when I was an adult primary care doctor, I tried to help a lot of people with quitting smoking. And the biggest piece of advice that I wanted to give was, even if you don't succeed the first time, just try again. The more times you try, the more likely you are to succeed. So.
Oh, that's good. That's good advice. Thank you.
Yeah. Don't give up if it's tough, because quitting smoking is not easy. I understand. But of course, especially with sickle cell, but really for anybody, it's life-saving to quit smoking. All right, Stephanie, go ahead.
Thank you. I do take up sobriety. At the moment, we have put it on hold because of some information from somebody that works with ASH that there's a concern about, for people who have had clots before, that there may be some stroke components to it. And I have to have my hip replaced, hopefully soon. So we're off of it until I finish that, and then we'll probably go back on it, because it did a good job of raising my hemoglobin.
That's great. Yeah, that's a really good point. Of we don't know what the long-term effects are, and all we know is what we studied, right? In this trial that was about 48 weeks. So when it comes to things like clots or the risk of increasing your hemoglobin, it's definitely things that we have to think about. Sorry, did I cut you off? Did you have?
No.
Okay. Yeah, and there is this concern. I don't know if anybody's ever been discussed about why we don't transfuse up to a normal hemoglobin amount of 13 or 14, which is what people who don't have sickle cell disease normally have, right? Even when we transfuse, our goal is, closer to 10 or 11. We try not to get too high. And that's because even with healthy blood, your blood vessels are a little bit stickier. And I worry about what we call hyperviscosity, which means that just the blood can be kind of sludgy. And so there is this risk, right? If hemoglobin gets too high with Voxelitor, could it be harmful because there's too much blood in the body? And, so far our data has not supported that. It shows that because the blood cells are healthier, because it's leading to healthier blood vessels, that Voxelitor really is, even when it raises the hemoglobin, it has a benefit. But I think that we still have to wait for more experience and more data from this. All right. So let me move to just the last approved medicine. The goal of this medicine, called crizanlizumab, or Adakveo, which is made by Novartis, was we understood that there is a lot of stickiness that plays a role in disease. This is interesting because this has nothing to do with the red blood cells. This has to do with the blood vessels and our white blood cells and platelets sticking together and causing kind of sludging in the blood vessels because of it. And they identified that there's this one protein called P-selectin, which is upregulated. There's more of it in inflammation conditions like sickle cell disease. And so they use this as a target. This is a protein that's on blood vessels that blood cells can bind to and target. So what Novartis did, this drug company, is they created an antibody. They created a protein that can be infused to bind to this protein called P-selectin and prevent our blood cells from sticking to it. So essentially making this like a anti-stickiness agent. So this drug, crizanlizumab, was studied in about 200 patients. This is older patients, 16 and above, with all genotypes who had more severe disease, at least 2 pain episodes, if not more. And people who are on hydroxyurea were eligible. So we've studied this in people with hydroxyurea, but people on chronic transfusions were not eligible for this trial. And again, it was randomized. People either got a saline infusion or crizanlizumab for 1 year. And they stratified the randomization to make sure there was kind of an equal number of people in each group who were on hydroxyurea and who had severe disease. And they looked at the incidence of pain crises. And again, it was pretty similar to what we saw with Indari, that there was a modest decrease. Of course, this drug was not a magic drug that like removed all the pain, but people who were on the high dose crizanlizumab group had about 1.6 episodes of pain versus like 3 episodes of pain in the group that didn't receive crizanlizumab. The low dose crizanlizumab group had a slight improvement in pain, but didn't meet significance. You can see that on these graphs here. The yellow group of this is the rate of incidence over time. You can see right off the bat in the first couple of months, there wasn't a big difference both in the time to the first episode and the time to the second episode. But over time, over the course of 12 months, there was a reduction in the amount of pain episodes that patients had compared to the placebo or compared to the lower dose. And so about a third lower pain crises in the treatment group compared to, in the treatment group. And this is to say that the people who were taking hydroxyurea had a lower pain incidence than people who weren't taking hydroxyurea. The biggest side effect that was seen in this study was joint pain. And just in our real world experience, I think that we've seen a couple of patients who report that their pain gets a little bit worse when they're taking Adakveo, and especially during the infusion itself, some people report pain. So actually the drug company recently updated their practice guidelines so that we actually give Tylenol before the infusion to reduce the incidence of pain. So like I said, I mentioned kind of how this is given, but this is now approved for kids 16 years and older who either don't have a complete response to hydroxyurea or L-Glutamine, or who are still having pain regardless. And it's given as an IV infusion. And so you have to come into the clinic to get it infused. And it's done initially every 2 weeks for the first 3 doses, and then every 4 weeks. So it's once a month infusion after kind of an initial period. Takes about 30 to 60 minutes to infuse, and it's done in the infusion center. And most people tolerate it fine, but because of this infusion-related pain, we now prescribe Tylenol for everybody before. We don't really have to adjust the dose for kidney or liver dysfunction, but we don't know about its safety in pregnancy or lactation. So these are my thoughts for this. This is good for people who have severe disease despite taking hydroxyurea and glutamine, meaning have a lot of pain, because the outcome that was studied in this was pain. It could also be a good one for people who have a hard time with daily meds. This is a once a month infusion, and you have to come into the clinic for it, but you don't have to take a daily med for this to be effective. So that's nice if, taking pills is difficult, you're in different places and can't take pills with you. It's a potential option. And then we don't really have a good sense of which patients would be best for this. We think about it for people who have a lot of pain despite other treatments, but potentially can we find out, like Antoine was alluding to earlier, which patients have stickier blood and maybe which ones might benefit from this? Could there be biomarkers, lab tests that help with this? I don't know. I think that that's something that's to be determined. And then this is an extremely expensive medicine. Any antibody, any infusion, they're very expensive. Unfortunately, we had it covered by most of our patients who we prescribed it for, but the pharmacy puts up some barriers sometimes for it. So what have you guys heard about crizanlizumab or Adakveo is the other name for it, and what's your experience been? Janelle, I might call on you to share your experience. Oh, there you are.
Okay. I did try this drug for maybe like 3 months. It didn't really affect me when I was getting the drug, like through the infusion part, but later on when I was at home, I had very bad pain crisis. And I would have pain in places where I didn't have pain before. Like, usually my pain is in my chest, my back, or my hips. But I was having pain in my legs, like my lower part of my legs, or my arms, where I never have had pain before. And it just kind of made me feel like it was causing me to have more pain instead of taking away the pain. So, I tried it for 3 months. I, gave my best shot at it, but I decided not to continue because it every time I got the drug, when I came home, I would have pain, and it would be very, very bad to the point where I would want to go to the hospital. So I just decided to not take it anymore.
Got it.
But
yeah, I've heard. Go ahead.
I was gonna say, but to each is his own, you know, maybe if I may have stuck in there maybe for a year, maybe it would help, but I didn't want to deal with the pain, you know.
And that's, you know, I've heard at least a couple of other patients tell me the same thing. And of course, I've had other patients tell me that they do feel a benefit. So it has to be individual. So typically when I'm talking about crizanlizumab with my patients, I suggest, you know, giving it a 6-month trial. And of course, stopping it earlier if you're really not tolerating it, but giving it a trial for 6 months so that we have a, you know, relatively long period of time where we can assess whether it's changing, how often you are needing your home pain medicine or need to go to the hospital, or, you know, to make kind of a good, give it a good shot. So, you know, I hate to start a medicine and not have a plan for it of, you know, is this something we're going to be on forever or just for a little bit? So 6 months is typically, you know, there's no magic to that. It's just a number I kind of thought of on my own. And when I talk to patients, we can kind of come to an understanding of what is our goal for this and when are we going to reevaluate. And that should be true for any medicine, right? I think that should be true for any change that we make to your plan, is having a plan, not just for today, but for what comes next. So this is just kind of a summary of the current drugs we have available. And I should mention that there's at least a handful of other new drugs that are being studied. We're actually opening up some clinical trials in Oakland that are studying some medicines with slightly different mechanisms that kind of target other parts of this pathway. And, you know, I want to emphasize all of these drugs are, the goal is to reduce symptoms and also to preserve your organ function. So, you know, it's hoping that if we improve the kind of global cycling process going on, that it has this twofold effect of improving pain and also preserving organs. Stephanie, yeah, please.
Yeah, thanks. I have found that one of the biggest things that I've done to actually shorten the amount of crises that I have is switching from like morphine and oxycodone to buprenorphine. The Subutex does not give me the same kind of opioid-induced analgesia that the others do. And I had thought that was what was going on because I had a teacher who had given me an article on it, but I wasn't sure. And so we decided to go off the opioids. And at the time that we did this, I was going in the hospital every month, sometimes twice a month. Mm-hmm. And the last time I've been in the hospital is October. So we are 8 months out. And that has really, and that wasn't even really like what it was supposed to do. Mm-hmm. You know, that wasn't the selling point of the Subutex, but that is how it has worked for me.
Thank you so much for bringing that up. And, you know, I kind of deliberately didn't talk about specific pain medicines during this talk, because I think that that's a whole separate discussion that I think is worth dedicating time to when it comes to Subutex or even other medicines like ketamine or methadone, and non-opioid type of medicines like Cymbalta, Lyrica, antidepressants that can have a pain effect. You know, I think that there's so much to talk about when it comes to managing pain. And what I also really want to emphasize is that if we only deal with pain, we're not dealing with what's causing the pain. And what's causing the pain is also causing organ damage. And so that's why I think that it's really important as a hematologist to listen to you guys about what's causing impacts in your day-to-day life, but also to share what I worry about in the background that you might not necessarily be feeling on a day-to-day basis, but could potentially impact your health long-term. So that I love the discussion about pain medicine, and I hope that we have another avenue to talk about our novel techniques and share other, you know, herbal remedies or natural remedies or other medicines that can help with pain in the future. Yeah, Karen, go ahead.
I was just, what is it that as a result of the sickle cell crises or just having anemia, what is it that, how does it impact the organs? Just like basic.
Yeah, no, that's a great question. There's probably a lot of factors to it, but probably the most important is, we need oxygen in order for our organs to function. Oxygen helps us generate the energy for our organs. It helps to, our cells need oxygen in order to do their regular processes. And if we don't have sufficient oxygen, then our cells are kind of under stress and they have to come up with other ways to kind of compensate for that lack of oxygen. And sometimes they just get tired and burnt out. I mean, it's basically like any of our jobs during COVID, right? Where we are being asked to do a lot more than we're given resources for. So over time, they get tired and they get burnt out. And this is just such a, global, big picture description of what's a much more complicated process that I can only begin to understand myself. But essentially, it's just your body's running on lower fuel than it wants.
Okay, thank you.
Yeah. I have a little bit more to talk about, but and then we can get to the just kind of general discussion. But just before we move forward, these drugs aren't free. And I think that this is going to be a really big thing that we need to discuss in the future. This is a report from ICER. I forget what ICER stands for, but it basically looked at the cost effectiveness of these drugs and showed that really none of the new drugs are, from what we know right now, the balance of kind of the cost of the drug versus what we're saving in terms of reduced healthcare utilization. We don't really have a good answer for that. Hydroxyurea is thankfully very affordable, but the other ones are not. So this is going to be something where the more we use it, the more we'll have an understanding of what the benefit is, keeping patients out of the hospital, keeping patients out of pain, improving the productivity of patients because they can go to work and feel good, improving their lifespan. I think that there's a lot of benefits that outweigh the cost, but the jury's still out on kind of the numbers for that. But I just wanted to share this with you, show you that these drugs are unfortunately very expensive. So just basically my overall thoughts on this is that sickle cell disease is so complicated and there's so many more aspects of this than I think we gave it credit for back in the 1950s when we were just learning about it. And targeting just one piece of the puzzle is not sufficient to deal with everything else going on. We do have some drugs, and there's been a bunch of other studies that have had disappointing results, but now that we have these new medicines, perhaps revisiting some of those old drugs to see, is there synergy? Can they work together? Is there kind of a additive benefit of, different meds? I think that we have a lot of work to do to figure out how to use all the tools in our toolkit to improve an individual's course. And of course, this has to be individualized. One patient's pain and one patient's symptoms has to be taken individually, and we can't really come up with a one-size-fits-all treatment for sickle cell disease. It has to be individualized based on what you're telling us. Yeah. Comment? I'll finish up just really briefly talking about curative therapies.
I have my hand raised.
Yeah, I called on you. You didn't say anything.
That it went out. I didn't hear that.
Oh boy, I'm sorry. Go ahead.
I just, you were talking about the cost of those drugs. So how do clients, there's got to be some way that you work with the clients in order for them to receive this, right?
Yeah, for sure. And thankfully, insurance and the drug companies are very motivated to help patients. And I think that, especially for GBT, in addition to developing drugs, I've heard a lot of enthusiasm from them to improve access to the drugs too. And so fortunately, we haven't had a lot of our patients need to pay a lot out of pocket, or we do get these authorized. Sometimes we have to jump through a couple of insurance hoops to get them authorized. And in my experience, and Robin, maybe you can share, Indari seems to be the most challenging one of these new meds to get approved. But thankfully, I don't think that the cost has trickled down to the patient. I think it's more from the insurance standpoint.
Okay, great. Okay.
Yeah, but it is hoops. And so when we prescribe any of these, it takes a couple of weeks to get approval. And so we just have to be patient about it, which is, I wish I didn't have to ask my patients to be more patient than they already are. Yeah. So I'll breeze through this because this is really beyond the scope. It can be a whole different talk. But a curative therapy is something that impacts the root cause of the disease without having to take other medicines. So while it would be great to eliminate the clinical manifestations, which really our current strategies of medicines really just slow the progression of disease. So an ideal curative therapy would be widely available, have minimal toxicity, really be safe, and you can use it early in life before you lead to any irreversible organ damage. So, and in low resource settings, really where most of the people in this world with sickle cell disease live, it's really important for this to be affordable, available, and effective. The first bone marrow transplant for sickle cell disease actually was in a kid in the 80s with leukemia. She developed leukemia and had to get a bone marrow transplant for that. She also had sickle cell disease, but when she got a bone marrow transplant for her leukemia, her sickle cell disease was cured. And so this really led to thousands of individuals getting transplants for sickle cell disease since then. But unfortunately, in order for you to have a successful transplant, you need to have a match, a bone marrow match. And a matched sibling is the best. But only 14% of individuals with sickle cell disease in this country have a matched sibling, and only 20% of them have an unrelated donor, so somebody who's not their sibling. And of course, there's a lot of toxicity related to what it takes to go through a transplant, because you need to get chemotherapy and things like graft versus host disease, where the donor bone marrow is kind of attacks your body. These are definitely things that patients need to be counseled on and might limit its broad use. In recent decades, we've improved our supportive care. Our technology to identify donors has reduced significantly. And so it is still done frequently. We have a couple of patients in our hospital right now in Oakland getting transplants. And it is an option, but we have to be transparent about the fact that it's a risky option.
So I have a question about, not a question, but just your thoughts on with the new medical therapies that are coming out, and then you have gene therapy and stem cell. Doesn't stem cell or gene therapy fall in the curative?
It does, yeah. I'll get to that right away.
Okay. I'm sorry, I didn't mean to rush you.
No, not at all. On the American Society of Hematology, which is kind of our governing body that helps come up with guidelines, just put out some consensus statements in 2021 about transplant and who should be referred. So really, just because of the risks, that absolutely does not mean that we shouldn't talk to our patients about transplant. I think everyone has the right to be informed about it and to learn about it and make a decision for themselves whether it's a reasonable option to move forward with. We do recommend that people are referred if they've had stroke or are at risk for stroke, if they have really frequent pain requiring hospitalizations, if they have multiple complications like acute chest syndrome. And we know that children under age 16 tend to have better outcomes than older patients, especially when they have a matched sibling compared with patients who are older. HSCT means hematopoietic stem cell transplant. That's just another word for bone marrow transplant. And then there's a couple of other kind of recommendations that they make here, but really the point I want to make here is that, transplant is something that we ought to talk to our patients about. And it's not something that we as, like, I like what you said, Stephanie, right? We can't make a decision about what's important to you. You make a decision about what's important to you. And so our goal is to tell you about all the available options and to counsel you on them. Of course, tell you what we think is a good idea or not a good idea based on our assessment, but you get to make the decision about your own health and life. So I appreciate that sentiment. And then the brand new therapy that we have, gene therapy or gene modification, actually, the goals of this is to change the genetics of our blood cells so that we're producing healthy red blood cells. And you'd think that the simplest thing would be, hey, you have a sickle gene, let's just replace it with a normal gene. That is being studied. We have a new study that's opening up in Oakland very soon that is using this CRISPR technology you might have heard of to do that. But there's a lot of other targets like inducing an anti-sickling hemoglobin, increasing fetal hemoglobin expression with gene editing that can be done with multiple different technologies, many of which are very, very complicated and require lots of PhDs to be in the room for. But this is being studied right now. There are no available approved treatments. And of course, there are risks, things like chemotherapy and need to be in the hospital for a long time. That need to be addressed when we talk to patients. But of course, the biggest thing that we do here at our hospital, you guys might recognize this, is prevention. Nothing is more important than preventing symptoms or organ dysfunction. That is our priority. And this can be through the use of counseling, coming up with individualized pain plans, both for home, the emergency room, and inpatient, that we're hoping are going to be a routine part of care, and also screening for organ injury. This is just a list of the things that we might discuss with our patients, like MRIs of the brain to look for stroke, echoes or ultrasounds of the heart, pulmonary function tests, look at lung function, checking eyes, looking at bone density, blood work, of course, urine, checking the liver and the heart for iron overload. These are things that we'll be nagging you about to make sure that we're assessing your organs, because these might not be symptoms that you feel. And we hate to, my goal is to look at your heart before it gets sick so that we can intervene, rather than looking at it only after it gets sick. And so this is, I'll just reintroduce our team here of all of the things that we want to do to keep you guys as healthy as possible. So I'm here, we have some other hematologists on the team, but Celeste, our social worker, Kristen, our patient navigator, and Robin, our amazing PA provider. All of us will work together not only to make an assessment about what is necessary for our patients, but to figure out what the barriers are to getting them done, figuring out transportation, figuring out insurance, all of the things to ensure that care is being provided for prevention, because I'd love to prevent symptoms rather than dealing with them when they come on. So that's the goal of not just medicine, but all of these other screening things and plans for you when you're out of the hospital. Yes, Nidita.
How often are you at ZSFGH?
I am there. So we have clinic every Monday, except for holidays, of course. And I split my time. I'm a sickle cell doctor, but I also take care of other patients with hematology issues, both at the Children's Hospital in Oakland as well as the pediatric hospital in San Francisco. And right now, because of our resources in terms of space and also just the number of patients that we see, we have clinic every Monday, and I'll be there most of the time except for when I'm inpatient. And Robin is there, as you guys all know, Robin is amazing and is there all the time. Right now we don't quite have, we want to make sure that we're maximizing our use of the Monday clinic before opening up another clinic. And so certainly as we meet with you guys and hear what the needs are of the community, we can come up with a strategy to increase our clinic presence. And, our goal is also, Monday is when we're there in clinic, but we want to be your team no matter what, when it is. So reaching out through my chart, reaching out by phone, understanding how to get a hold of us, even if it's not on a Monday afternoon, is our priority. But for now, I'm there all the Mondays that I can be, which is most Mondays.
Any conversations about extending the clinic hours?
I hope so. And, part of the clinic is, of course, what Robin and I do in terms of the medical assessment and prescribing meds and screening and just, chatting about how you're doing functionally. But the other part of it is what Kristen and Celeste are doing in terms of neuropsychology testing or needs assessments or other parts of your health that might not necessarily be specific to sickle cell, but are impacting your experience with sickle cell. And those may be happening outside of that just Monday afternoon time, either by phone, by telehealth, or sometimes even in person. But based on our current clinic availability, we have to have a room available. We certainly don't want to be just like meeting you out in the hallway, right? We want you to have privacy and the appropriate setting to do our work effectively. Right now, it's still once a week. We're hoping to make this once a week to get the most bang for our buck, and then prove to the people in administration that it's necessary to have more time.
Well, it's good that the key people are in place with the social worker and the program director, and that you guys are allowing yourselves to be available, via telemedicine, telephone, video, what have you, so that they know that they have options. And even if they can't necessarily get an appointment, they can still reach out and get some assistance and advice.
Yeah, and we
really appreciate.
I don't want to overpromise, right? Because we Robin and I are both stretched when it comes to taking care of our other patients as well, and so we really want to do our best, and we promise that we will do our best. I can't promise that our best is always everything you need, but we sure will try.
Well, yeah, but if you've got that in the forefront of your mind, my mom always said, hey, if you do the best that you can do, then that's all that you can do.
Yeah, and I always say that I can't promise that I'll have the solution, but I'll promise that I'll try.
Great, great.
All right. So this is just my last slide, just to wrap up. Kind of, I've been rambling for 2 hours, so you know what I'm talking about. You know, there's been so many advances in our understanding of the disease process as well as the medicines. And throughout all of this, it's led to the approval of 4 drugs, which I think is more than we could have said us a couple of years ago. But really, we're on the cusp of, I think, a really important change in sickle cell disease. There's so much, you know, most of what I follow on Twitter is sickle cell, and there's just so much enthusiasm and excitement about it right now, both from patients and advocates and warriors, and also from providers. So there's a lot of barriers to providing excellent care, but lack of knowledge should not be one of them. And that's kind of what I'm super excited to be part of as a new hematologist in this field. And with that, I would love to answer or take any questions or share if you guys have questions for each other. That's all I got. I'm going to stop sharing so we can see each other.
Beautiful, beautiful. Once again, I want to make sure that I stress those that have been a part or participating in this presentation. If you have not filled out the survey, please do so as soon as you possibly can before we log off, or else you'll lose the link for that. This is your key to being able to get the slides and also the first chance to get the video edit of this presentation. We do have a videographer that edits this recorded video, and we do have a media channel at youtube.com. All you got to do is when you go on YouTube, you can put in SCAASF and it'll show up our page. You can subscribe to it and then get all of the AEP sessions, webinars, and other things that we have done in terms of media and video. We have everything from 2020 when we first started the program to 2021 and even going into this year. I think Nadina can attest this. We have 2 more of these webinars left for the 2022 year. We're working on something that we're trying to develop for Juneteenth, which is June 19th. That's World Sickle Cell Day. So make sure if you guys want to get more information on that, you can go to our website. You can type in scaasf.org and it'll go straight to it. Or if you guys using Google, you can put in Sickle Cell Anemia Awareness of San Francisco, and it'll take you to that link as well. Thank you, Dr. Vissa, for all of this great information. Honestly, this has been a very comprehensive presentation, and I'm sure that you convey this in a manner for all parties to be able to understand. And I'm very impressed by your group's abilities and what you guys are working on in the future. Like we said, there's a lot of people that are, how do I say this, invested into this vision that have been living for 50 to 60 years plus that are starting to lose hope. So the more and more programs that we can align ourselves with, collaborate with, to show these people that there is hope and it shouldn't be lost, that only bodes well for us to build more strength and foundation for the more youthful people in this community, so that they can continue to fight for the necessities that are going to continue to help their sustainability, their living situations. Nadina, do you have anything else before I close this out? You're on mute?
No, just that I really appreciate all of you taking the time out to be a part of this session and get all this valuable information. And Dr. Vissa, I really appreciate your time and all of the information you conveyed today, which was very, very helpful for me, and I'm certain for a lot of people that were in the session. So I thank you, and I look forward to working with you all.